بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة. هذه تكملة محاضرة allergic rhinitis. So the treatment of allergic rhinitis, we start with the avoidance of allergen, but it is not possible in many of the cases. So we depend on the use of the oral antihistamines, and then the mainstay of treatment of the allergic rhinitis is the use of intranasal corticosteroids in the forms of drops and sprays, with the use of the leukotriene receptor antagonist, especially if the patient with allergic rhinitis has nasal polyps. And the last resort in the management of allergic rhinitis, if all of the above measures fail, we depend on allergen immunotherapy. Avoidance of the precipitating allergen is obviously helpful, but not always possible. So we depend on the pharmacotherapy. We start with the use of the antihistamines. These rapidly relieve running, itching, and sneezing, but have little effect on nasal blockage, because the antihistamines block the effect of the histamine, which is responsible for the early phase of allergic rhinitis, while the late phase of allergic rhinitis, it is caused by the mediators like the cytokines and the leukotrienes. So the antihistamines are not effective in controlling the nasal obstruction, which is a feature of the late phase of allergic rhinitis. We use the cetirizine and levocetirizine, fexofenadines, loratadine, and disloratadine. These are new generation antihistamines. We should avoid the first generation of antihistamines like chlorpheniramine and diphenhydramine because of their side effects. The side effects of the first generation antihistamines are sedation and the anticholinergic effects. The mainstay of treatment of the allergic rhinitis is the use of topical corticosteroids in the forms of drops like betamethasone or sprays like beclomethasone, mometazone, fluticasone, triamcinolone, and budesonide. These topical corticosteroids are the most effective treatment for allergic rhinitis. We also can use sodium chromoglycate spray. It stabilizes the mast cells and prevents them from degranulation despite the formation of IgE antigen complex on the surface of the mast cells. Another medication which are used for the treatment of allergic rhinitis are decongestants. The topical decongestants only used as a very short-term use, not more than 3 to 5 days, because of the side effect of prolonged use of these nasal decongestants, which is called rhinitis medicamentosa. So we can use them for a short term for flying, for otitis media with effusion, and rhinosinusitis. The systemic decongestants, they are not effective. Another medication used for treatment of allergic rhinitis is ipratropium bromide. It is an anticholinergic drug in the form of spray, which is effective for rhinorrhea. Systemic corticosteroids, these can be used to unblock the nose at the start of a treatment or provided for very severe symptoms with topical treatment. We can use topical and systemic steroid, but the systemic steroid should be used for a short term because of their side effects. The anti-leukotrienes, they include Montelukast, Pranlukast, and Zafirlukast. They are used if polyp is present. Nasal douching, nasal irrigation and douching by saline or seawater can improve the quality of life. If all of the above measures are failed in controlling the allergic rhinitis, so the last resort is the immunotherapy or hyposensitization or desensitization. It is designed to induce tolerance to an allergen, therefore to reduce symptoms caused by exposure to that allergen. The value of the immunotherapy is to suppress the formation of IgE. Immunotherapy is used when the drug treatment fails to control symptoms or produces intolerable side effects. The immunotherapy is available for the common allergens like grass and tree pollen, dog and cat, and dust mite. Treatment involves an updosing phase over several weeks and then a prolonged maintenance phase for 3 years. Allergen is given gradually in increasing doses till the maintenance dose is reached. Rhinitis medicamentose is a rebound congestion that occurs with a long-term use of intranasal decongestant. The decongestant that contain alpha-adrenergic compounds such as phenylephrine, oxymetazoline, or xylometazoline. These topical decongestant substances should not be used more than 3 to 5 days. And the root of the problem lies in the fact that once the effect of nasal decongestant has worn off, there is a rebound vasodilatation. Treatment of rhinitis medicamentose involves avoidance and cessation of the decongestant with the use of topical steroid, topical nasal steroid, and in some cases short-term of systemic steroid. Where turbinate hypertrophy is a major feature, turbinate reduction may be required, and reduction of the turbinate by cauterization or by electrical cauterization or by ultrasound or by turbinectomy, partial turbinectomy. Prevention of rhinitis medicamentose by education of patients is important. We should instruct the patient to avoid use of these nasal decongestant for long time. Good luck.